So students, here we are going to have a rapid revision of pharmacology, that is general pharmacology. Now important definitions that we usually discuss are pharmacology is the science of drugs, then a bit about the history. Okay, then we'll be seeing categories of drugs, then we have routes of drugs administration, followed by pharmacokinetics, in which we have absorption, distribution, metabolism, excretion, and then we'll be discussing about the pharmacodynamics karenge, and then we have ADME, that is therapeutic drug monitoring. So these are the things which we are going to discuss in general pharmacology, and then the phases drug trials. Right now this is going to be a rapid revision here, like very exhaustive. It is going to be that, so stay connected. Now in the history, if I talk about animal experiments in 18th century, they were done by F. Magendie and Claude Bernard, right? Then Rudolf Buchem started pharmacology as experimental science, and he founded the institute in Germany in 1847. Then we have Oswald Schmidberg. He is called as father of pharmacology, right? Pharmacology is divided into pharmacokinetics and pharmacodynamics. So pharmacokinetics is the effect of body on drug, and pharmacodynamics is effect of drug on body. In pharmacokinetics, we study about absorption, distribution, metabolism, and excretion. Here we study about receptors, okay, mode of drug action and factors affecting drug action. Now let's see what are the categories of drugs. So what are the categories of drugs? First category is spurious. You will have some questions where they'll ask you, they'll give you a name, they'll give you a detailed description, and they'll ask you what is the category of this drug. So you have spurious, you have misbranded, you have adulterated, then other drugs are there. So spurious is when there is an imitation of another drug in the name, right? When there's an imitation of another drug in the name, then it is spurious. Misbranded is not labeled properly, having false claims is misbranded. Adulterated means it is filthy, has got some bad thing, decomposed substance added to it. That is adulterated, right? Then safety in pregnancy. Drugs are classified for their safety in pregnancy. So all the drugs are allowed except for category X, which is contraindicated completely. So remember, like category X drugs are contraindicated in pregnancy. बाकी सारी categories फिर भी उसमें क्या होता है, risk, potential, benefit versus risk is same, but category X absolutely contraindicated. Then let's see the schedules. Schedules of drugs are very important. इसके ऊपर बहुत questions आते हैं. So there is something called as schedule X. X is narcotics and psychotropics. They're also described as like this, NRX. Okay? Then we have schedule H. H scheduled drugs are given by prescription only. They are not given like that. So they have to be prescribed, and then only the pharmacist will give them. Then we have, what is that? Next, we have OTC. OTC matlab over the counter drugs. So these OTC drugs are given over the counter. They don't need a prescription. Okay. What is an orphan drug? An orphan drug is a drug which is used for rare diseases. Okay. It is a drug, rare disease, less than 5 lakh persons. So that is classified as a rare disease. Okay. In the same category, in the same light, we have another definition, essential drug. What is an essential drug? An essential drug is a drug that satisfies the priority healthcare need of population. Right? इसमें important है. Latest list was released in September 2022, which has 384 medicines and 23 FDCs. ठीक है? Now next we come to routes of drug administration. ठीक है? So what are the various routes of drug administration? Now routes में देखो, various routes that are given. We have local, and we have systemic. Local routes are further divided into topical, intra-articular and intrathecal. Systemic routes are divided into enteral. Enteral में होते हैं oral and rectal. Systemic इधर होते हैं parenteral. Parenteral routes में आते हैं IV, IM, subcute, sublingual, transdermal, nasal and inhalational. Okay, so these are the various routes. इसमें important है इंजेक्शंस के एंगल्स. इस पर क्वेश्चंस आते हैं. एंगल्स क्या होते हैं देखो. इंट्रामस्कुलर का होता है 90 डिग्री, सबक्यूटेनियस का होता है 45 डिग्री, इंट्रावीनस का होता है 25 डिग्री एंड इंट्राडर्मल का होता है 10 to 15 डिग्री. ओके, दीज आर द एंगल्स. नेक्स्ट आगे बढ़ते हैं. इन्हीं में ओरल रूट, वेरी हाई फर्स्ट पास मेटाबॉलिज्म. फर्स्ट पास मेटाबॉलिज्म मतलब जो भी मेडिसिन आप ओरली खाओगे दे विल फर्स्ट गो टू द लिवर एंड देन दे विल बी मेटाबलाइज्ड एंड देन दे विल गो टू द सिस्टम. ओके, रेक्टल रूट से अगर हम देते हैं मेडिसिन तो रेक्टल रूट में 50% फर्स्ट पास मेटाबॉलिज्म में चली जाती है. एंड एनी ड्रग दैट यू कैन रिमेंबर दैट इज डाइजेपाम विच इज गिवन इन फेब्राइल सीजर्स, राइट. देन आईवी रूट 100% बायो अवेलेबिलिटी होती है. देयर इज नो फर्स्ट पास मेटाबॉलिज्म, राइट. सबक्यूटेनियस रूट की खासियत क्या है दैट इट कैन बी सेल्फ एडमिनिस्टर्ड. इंट्राडर्मल रूट की खासियत क्या है कि ये यूजुअली डायग्नोस्टिक टेस्ट के लिए यूज़ किया जाता है और इसमें एक ब्लैब बनता है. ये ध्यान रखने की ज़रूरत है. ठीक है. ट्रांसडर्मल रूट, ट्रांसडर्मल रूट से हम देते हैं हाईली लिपिड सॉल्युबल ड्रग्स लाइक एनटीजी, फेंटेनिल, हायोसिन. ओके. नेजल रूट, नेजल रूट से हम देते हैं ड्रग्स लाइक नेफेरेलिन, कैल्सिटोनिन, डेस्मोप्रेसिन. ओके. इनहेलेशनल रूट, इनहेलेशनल रूट से हम देते हैं इट इज़ लाइक आईवी. So the drugs which are given inhalational are asthma drugs, inhalational corticosteroids and inhalational anesthetics. They are also given by this route. Then we have sublingual. Sublingual route से हम देते हैं drugs in emergency like NTG देते हैं and it avoids the first pass metabolism. It is used in emergencies and it can be self-administered. Right? So these were some details about the routes of administration. Now we come to the pharmacokinetics. So pharmacokinetics में सबसे पहली जो चीज़ हम पढ़ते हैं वो है absorption. Okay, absorption सबसे पहले पढ़ेंगे. Now in pharmacokinetics, now starting with the absorption, the main you have to understand two main fundamentals: ionization and lipid solubility. So we know that more lipid soluble drug will cross the membrane and less lipid soluble. So if it is more lipid soluble, it will cross, and if it is less lipid soluble, it will not cross. Same way in ionization. Ionization में unionized drugs cross and ionized drugs do not cross the membrane. This is the basic fundamental that you have to remember. When the drug gets ionized, then it crosses the membrane, and when the drug is unionized, it does not cross the membrane. Okay. Acidic drugs will do what? One second. Acidic drugs remain unionized in acidic medium, and so they will cross or get absorbed in stomach. ठीक है. And basic drugs will remain unionized in alkaline medium, and so they will cross or will be absorbed in intestine. Got it? So that means acidic drugs absorbed in stomach. Okay. And basic drugs are absorbed in intestine. Aspirin is one drug, acidic होती है. Aspirin is an acidic drug and this is absorbed in the stomach. Stomach में लेकिन इसके साथ एक phenomenon attached होता है, that is called as ion trapping. क्या होता है? Aspirin from the gastric lumen, it is absorbed into the gastric mucosa. There the pH is alkaline and hence it gets ionized. And now that it is ionized, वो वहीं पे trap हो जाती है. It is trapped in the gastric mucosa. And that is the reason why it causes gastric damage, right? Another fundamental, another concept, phenobarbital. Phenobarbital is a barbiturate, right? It is an acidic drug. So it gets ionized in alkaline urine. Phenobarbital acidic drug होती है, ionized in alkaline urine, and so treatment of phenobarbital poisoning is done by alkalinization of urine, right? Now moving forward, we have a very important concept to discuss, that is pKa. Now what is pKa? pKa is the pH at which the drug is 50% ionized. Okay, so understand this concept. It is the pH at which drug is 50% ionized. So when pH is equal to pKa, ionization is 50%, right? When pH minus pKa is equal to 1, then one form is 90% and another is 10%. When pH minus pK is equal to 2, then one form is 99% and another is 1%. Remember this. So here comes a formula that you need to remember. What is that formula? pH is equal to pKa plus log of ionized form upon unionized form. Okay, this is the formula for pH and pK. Now coming to a next concept, that is bioavailability. Now bioavailability is the fraction or F of a given dose that reaches systemic circulation in unchanged form. Okay, that is bioavailability. Now remember, orally when you take a drug, it first reaches the liver, then it is metabolized in the liver, which is called as first pass metabolism, and this is first pass metabolism. Then it reaches the systemic circulation. Okay, so if we take about the routes, IV में bioavailability is 100%, intramuscular or subcutaneous में bioavailability is 75 to 100%, and oral में bioavailability is 5 to 50%. Okay, I forgot to switch on the camera. I'll again explain. Bioavailability is calculated from the area under the curve. So this is the graph plotting concentration versus time graph, where time goes like this, concentration increases like this. This is the area under the curve. Now this is Tmax and this is Cmax. Cmax is the maximum concentration achieved at a dose. AUC, that is area under the curve, is the extent of absorption, and Tmax is the time taken to achieve the Cmax. So Tmax actually is the rate of absorption, if I speak like that. Okay, now this is an example that I'm trying to show you. A graph is plotted like this. This is Cmax, right? And this is Tmax. Say Tmax is 2 hours, Cmax is say 100 concentration, and now this is 50 and this is 4 hours, right? So here Tmax is 2 hours, Cmax is 100 milligram per deciliter. Half-life. Now you can be asked a question that what is the half-life? Calculate the half-life. So remember, half-life is the time taken for the drug to become 50% of its original concentration. So from 100 to become 50, the drug takes 2 hours. So half-life is 2 hours, right? So like this graph can come and they can ask you this type of question. Then some other kind of questions also can be asked. Like this is the graph, right? This is Tmax, say it is 4 hours. Cmax, say it is 60. What is this? This is minimum effective concentration. This is minimum toxic concentration. So here again, Cmax is 60, Tmax is 4 hours, right? Drug should be given in less dose. This is important. Why? Because the Cmax, the drug is shooting above the minimum toxic concentration, and so this part is going to produce adverse drug reactions to the patient. So इस तरीके के questions में they can ask you that should the drug be given in single dose. So yes, yeah, they can ask you which of the following is not correct. Yeah, correct. So they'll give you some wrong options and then they'll write the drug should be given in multiple doses, divided doses. So then yes, that is correct. So this is how the concept of absorption, bioavailability is there, and the graphs. The next concept that we have to discuss is distribution. Okay. Now distribution is what? What is distribution defined as? Basically, distribution is a measure of amount of drug distributed in the tissues after absorption in systemic circulation, right? what is the formula? Formula, very important. Formula is equal to volume of distribution is equal to dose administered upon plasma concentration, right? This is the formula which you need to remember. So now here, what are the factors on which volume of distribution depends? The first is lipid solubility. Okay, more lipid soluble, more volume of distribution is there. The second factor it depends upon is plasma protein binding. More is the plasma protein binding, more is the volume of distribution. The third is crossing the blood-brain barrier. Again, depends upon the lipid solubility. That will increase the volume of distribution. Now, drugs with low volume of distribution remain restricted to vascular compartment. Okay? These drugs can be effectively treated by dialysis. Okay? Another concept that we need to discuss here is plasma protein binding. So plasma protein binding, we know acidic drugs, they bind to albumin, and basic drugs bind to alpha-1 acid glycoprotein. Okay. Now, plasma protein binding takes care of 3 things, 4 Ds, I'll say. Duration of action of drug. A high plasma protein binding will increase the duration of action of drug. Okay? Will reduce the distribution of drug. If the drug is highly plasma protein bound, then it will remain in the plasma. It will not go to the tissues. Then highly plasma protein bind drugs, then dialysis not useful. Because the drug is plasma protein bound, and because dialysis cannot remove those heavy proteins, so dialysis is not useful in high plasma protein binding. And fourth is increased displacement reactions. Because they are highly plasma protein bound, so the drugs show increased displacement reactions when they are bound to the plasma protein. So these are the 4 important parts which are related to the high plasma protein binding. So इधर ही अपन देख लेते हैं dialysis का effect. Dialysis, if the drug is high plasma protein bound, then not useful. For example, there is a drug diazepam, which is highly plasma protein bound, so it is not very useful. Then if the drug has got high volume of distribution, then it is not useful. Like digoxin. When is it useful? Low volume of distribution and low plasma protein bound. Okay? In दोनों conditions में dialysis is the treatment of choice in poisoning. Now another concept here. VD is the main determinant of loading dose. Okay? So the formula is loading dose is equal to VD into CPSS. This is a very important formula, and you have to remember this because a lot of questions are asked on this. And the second is clearance is the main determinant of maintenance dose. So that means maintenance dose is equal to clearance into CPSS. So this is the second important formula that you should know, right? The next thing that comes in distribution is tissue storage. So some questions come कि ड्रग कहाँ पे स्टोर होती है, ये ड्रग कहाँ पे स्टोर होती है. So remember, chloroquine gets stored in retina. Okay. Tetracycline gets stored in bone and teeth or interacts there. Streptomycin gets stored in vestibular apparatus, and emetin gets stored in heart and skeletal muscles. Okay, so these are the tissue storages which are important for the distribution. Now coming to metabolism. Now in metabolism, what is the definition? Or metabolism means to convert a drug into polar water soluble entity, right? Now in this you have to understand that there are some prodrugs which are basically inactive drugs, and they are converted to active drugs by metabolism. Then metabolism is divided into phase 1, that is oxidation, reduction, hydrolysis, and then we have phase 2 reactions, which are mainly conjugation reactions. Okay, so in conjugation reactions, then we have glucuronide conjugation, sulfate conjugation, glutathione conjugation, acetyl, methyl, methylation, what we call. So these are some metabolism reactions. Now coming to the first, that is oxidation. Now oxidation is done by enzymes which are called as monooxygenases. These are microsomal. Microsomal means which are present in the smooth endoplasmic reticulum, and they can be induced or inhibited. Okay. And then we have non-microsomal, which are basically present outside SER, smooth endoplasmic reticulum, and they cannot be induced or inhibited. Then we have sulfation. Sulfation, what are the drugs which undergo sulfation? That is very simple. We have sulfonamides, remember this, hydrolazine, then isoniazid, procainamide. So these are some drugs which undergo sulfation reaction. The specific thing is that they can cause SLE in patients who have genetic polymorphism. Then coming to the very important part, that is cytochrome P450 enzymes. Now you should know that cytochrome P450, suppose we take cytochrome P3A4. So this is standing for cytochrome P. 3 is the family, A is the subfamily, and 4 is the specific isoform. Okay, so this is the breakdown of cytochrome P450 enzymes nomenclature. Now the most important part, CYP3A4 enzyme. So what are the substrates? Now this is something that's gonna take time, but you have to be patient. So drugs like cyclosporin, tacrolimus, statins, cisapride, estomazole, terfenadine, then amiodarone, nevirapine, right? So PI inhibitors, basically protease inhibitors. These are the substrate for cytochrome P3A4. Then what are the inducers? Inducers, phenobarbital, phenytoin, rifampicin, carbamazepine, St. John wort. These are the things which can induce CYP3A4. What come in the inhibitors? Erythromycin, ketoconazole, fluconazole, grapefruit juice, ritonavir, cimetidine, and isoniazid. So these are the drugs which can inhibit the cytochrome P3A4 enzyme. So please remember, inducers में आप anti-epileptic को याद रखो. Phenobarbital, phenytoin, both are starting with P. P के बाद आता है rifampicin, carbamazepine, anti-epileptic. So carbamazepine, phenobarbital, phenytoin are inducers. Rifampicin, PQR, so nearer to P. Inhibitors, remember erythromycin, then ketoconazole, cimetidine. These drugs, fluconazole, are very commonly inhibitors. Okay. Then next we have CYP2D6. Okay. Now CYP2D6, what is the substrate? Substrate is tricyclic antidepressant, SSRI, MAO inhibitors, beta blockers, anti-arrhythmics. These are the substrates, except amiodarone. Okay. CYP2C19. What are the substrates? Clopidogrel and omeprazole. Okay. CYP2C9. Substrate, phenytoin, warfarin. CYP2E1. What is the substrate? Substrate is acetaminophen, that is paracetamol, halothane, and enflurin. Then we have CYP1A2. The substrate here is theophylline, okay, and warfarin. Okay, so these are the some drugs which are substrates at cytochrome P450, and they are inhibitors and inducers. Now let's talk about glucuronide conjugation. This is important. Where? Paracetamol, then diazepam, morphine, and metronidazole, right? Drugs which are having glucuronide conjugation are also having enterohepatic recirculation, okay, in which we have OCPs, thyroxine, and steroid hormones. So remember, drugs having EHC, that is extrahepatic circulation, are OCP is thyroxine and steroid hormones. Now, glucuronide is deficient in newborns, so it causes paracetamol poisoning, right? And then what is the toxic metabolite which is formed? That is N-acetylbenzoquinoimine. And what is the antidote? Antidote is N-acetylcysteine. Okay, so this is the thing that you have to remember. Now, next thing, enzyme inhibitors. Enzyme inhibitors में क्या होते हैं? Valproate, erythromycin, clarithromycin, omeprazole, cimetidine, metronidazole, ciproflox, amiodarone, and itraconazole. And what will enzyme inhibitors do? Enzyme inhibitors क्या करेंगे? They will increase the action, and they will do what? They will do toxicity. So this is what enzyme inhibitors do. They will inhibit the metabolism of these drugs. As a result, these drugs will remain in our system for a longer time. So these are very important points that I'm giving, and please remember them again and again. Then we have certain drugs which are enzyme inducers, right? Enzyme inducers में हमने बात करी थी, phenobarbital है, phenytoin है, carbamazepine है, ठीक है? Rifampicin है. There's another drug, grisofulvin. That is also an enzyme inducer. And what will enzyme inducers do? Enzyme inducers will reduce the action. So dose needs to be increased. And these drugs can precipitate acute intermittent porphyria. Okay, remember this. Now the next concept is first pass metabolism. Okay, so what is first pass metabolism? Today, I don't know, I have lost my pens. As a result, I'm not able to write all the multicolored things. So first pass metabolism, we know that it drugs before, when they're taken orally, then they go to the liver, they undergo a metabolism there, and then they go to the systemic circulation. So first pass metabolism, say, which reduces the bioavailability of the drugs. It is a safety mechanism or a filter kind of thing by the body. Drugs which have a high first pass metabolism are propranolol, verapamil, salbutamol, morphine. So these are the drugs which have got a high first pass metabolism. So oral dose is higher than parenteral dose. Okay. In liver failure, increase in bioavailability will occur, and so you will have to reduce the dose in liver failure. Okay, so you have to take care in liver failure cases. So this is all about metabolism. Next we move into excretion. So coming to the excretion part. Excretion में देखो, I'll draw the diagram also. This is the Bowman's capsule, and then this is the PCT. This is the descending limb of loop of Henle, then the ascending limb of loop of Henle, thick ascending limb, and then this is the DCT, and then this is the collecting duct. So this is CD, that is collecting duct, and this is the Bowman's capsule, right? So glomerular filtration happens through the Bowman's capsule. Okay. Then इसके आजू बाजू सब जगह veins चल रही हैं. So what happens is there is a phenomenon called as tubular reabsorption. ठीक है? And there is one phenomenon which is called as tubular secretion. ठीक है? So this is tubular reabsorption and this is tubular secretion. So now glomerular filtration को क्या क्या affect करता है? Renal blood flow and plasma protein binding. If the renal blood flow is good, then filtration will be good. If plasma protein binding is more, then filtration will be less because plasma proteins will not be filtered. Then tubular reabsorption. Tubular reabsorption किस पे डिपेंड करता है? Lipid solubility पे and ionization पे. So in the tubular reabsorption, the fundamental of ionization is applicable. If the drug is unionized, then it will cross and will be reabsorbed. If the drug is ionized, it will be excreted. And this fundamental was used in excretion of acidic drug, that is phenobarbital, right? And this is excreted out because we make the urine alkaline. So in alkaline urine, phenobarbital is ionized and thus it is excreted out, right? So this is used in the treatment of phenobarbital poisoning also. So this drug ionization, tubular secretion पे आते हैं. Tubular secretion is one component, and what is that? Penicillin and uric acid are two substances which are excreted through the same, which penicillin is secreted, uric acid is reabsorbed by the same transporter. So we use a drug which is called as probenecid. It is used in chronic gout patients, and it blocks this transporter, so reduces the secretion of penicillin and increases the excretion of uric acid. So it is beneficial in both the cases. Now, a very important part is kinetics of elimination. So kinetics of elimination, something which we have to understand properly. Here, rate of elimination is basically the amount of drug eliminated in unit time, right? And clearance is the amount of plasma cleared of a drug in unit time. Okay, so these are the two important definitions that you should remember. And what is the formula? Clearance is equal to rate of elimination upon plasma concentration. Okay, now a very important part that we have to understand here is first order kinetics and zero order kinetics. This is a very important concept and you please understand this very clearly. First order kinetics में a constant fraction of drug is excreted out, while zero order kinetics में a constant amount is eliminated out. Then here rate of elimination is directly proportional to plasma concentration. Here rate of elimination is independent. It is not dependent on the plasma concentration. Here clearance is constant. Here clearance is indirectly proportional to the plasma concentration. As the plasma concentration increases, clearance reduces. Here half-life is constant. Here half-life increases in ratio of plasma concentration. The drugs which undergo zero order kinetics are phenytoin, warfarin, theophylline, tolbutamide, alcohol, and aspirin. Okay, so these are the important drugs which undergo. These are the important points related to the first order and zero order kinetics, right? Now coming to the concept of half-life. Half-life is equal to time taken for plasma concentration to become half of original. So if the concentration is 100, it becomes 50 in first half-life, it becomes 25 in second half-life, it becomes 12.5 in third half-life, then it becomes 6.25 in fourth half-life, it becomes 3.125 in fifth half-life. So 4 to 5 half-lives are required for concentration to become negligible. Okay, so what is the formula? Formula is very important. Please remember the formula. The formula is half-life is equal to 0.693 upon K, and K is clearance upon volume of distribution. So half-life is equal to 0.693 into Vd upon Cl. Please remember this formula for half-life. You will be given the suppose the quantity of clearance and volume of distribution, and you will be asked to calculate the half-life. So this is how you have to calculate. So here you will see this is a graph that I am showing you, and in this, if we plot it as a plasma concentration time graph, then you will see that this is how the concentration will reach the CPSS, that is steady state plasma concentration, 2, 3, 4, 5. So it takes around 5 half-lives to reach CPSS. Okay, so CPSS depends on the dose rate. Fine. So another, we have already done this also, loading dose depends upon the volume of distribution into CPSS, and maintenance dose, the formula has clearance into CPSS. It depends upon the clearance. Now coming to the pharmacokinetic last part, that is TDM. TDM is called as therapeutic drug monitoring. Okay, now this is basically done for drugs with a low therapeutic index. We will see what is therapeutic index in the next class. For drugs whose effect is not easily measurable, and it is not done for prodrugs. Okay, so TDM is done for what all drugs? सबसे पहले आता है lithium. Lithium monitoring is done in when it is prescribed for mania. Phenytoin monitoring is done in epileptic patients. Then digitalis, aminoglycosides, and immunomodulators. Right? So it is done. TDM is done in these all cases. So with that, we finish the pharmacokinetics. Tomorrow we will be taking the pharmacodynamics.